today we'll be talking a little bit about vulnerable plaque by coronary CT. And we already have heard about vulnerable plaques through the invasive techniques, through IVUS, OCTA, and NERS. And suffice to say that there is a constellation of findings that is there in a vulnerable plaque, including the plaque burden, the minimal luminal area, lipid-rich plaque, and the TCFC. We also know that medical therapy, which is lipid therapy, is the cornerstone of treatment. What we do not know is local therapy, is it really effective or not? And that has been already covered. Now, we also know that the survival benefit for randomized trials, the ischemia trials specifically, did not show benefit simply because the plaques in a stable disease do not have the high-risk features that we're going to talk about, whereas the plaques in an ACS have all those high-risk features, including the thin cap, the lipid pool, the eccentric plaque, and also the lumen area. And that's the reason why the stable disease did not show any survival benefit, primarily because of the plaque morphology and not the degree of stenosis. So we're moving away from stenotic assessment to plaque assessment. We also know the pathophysiology goes by the Glago phenomena, and until very late, because of positive remodeling, you have a preservation of the lumen. So if you only do a luminogram, you're not going to detect the plaque till very late, and then when the negative remodeling starts happening, that's when you look at it. We know the various features of the vulnerable plaque, and that has been covered today evening, including the rupture, erosion, and the calcified nodule. We also know that there is a host of imaging modalities that are available now to look at them, starting from CTA, which has a very low resolution of 0.5 to 1, up to OCT, which has got an excellent resolution of 10 to 15, and IVUS and RF are somewhere in between. We know there is physiology of the NERS, which you can actually look at the lipid component, and we heard that lecture as well. But the important thing here is that the CT features are comparable to OCT, provided you have the right kind of picture quality, and more importantly, it's a very non-invasive technique. Moving from stenosis to plaque morphology, we are now looking actually at function and inflammation of the plaque, which seems to be a very, very important part of why patients have an ACS. And where would you use coronary CT in a line of patients is in a patient who has a low clinical likelihood. You're getting a high image quality on the CT. Local expertise, I think, is one of the very important issues. And these are patients who can be screened very quickly. It takes about 5 seconds for the scan, maybe 20 minutes. It's an intravenous injection, so completely non-invasive. And if you find that the patient has a normal coronary, they can be managed medically. Patient with a high-grade stenosis with a high-grade plaque feature directly goes to the cath lab, and anything in between gets a functional assessment. So it helps us in the routine workflow. Now, what exactly can CT do? So there are a lot of things that CT can do, starting from the calcium scoring, which is a great way to assess atherosclerosis, looking at the anatomy, the stenosis, looking at plaque morphology, looking at hemodynamic assessment, including CT-FFR, and finally, we're going to touch upon something called perivascular adipose tissue imaging. So CT has its own problems: radiation, lumen contrast, and obviously expertise. And what we do in CT is we identify the high-risk patient, guide the preventive measures, and we can actually monitor the plaque progression in some patients who have a high degree of plaque, but they don't have a significant stenosis. So let's talk about morphology. And these are the features that are available on the CT for morphology. The first one is the low attenuation plaque. You can see that. And this is comparable to what you saw in NERS, which is a high lipid concentration, and usually the HU is usually less than 30. And more the number of plaques you get a more vulnerable patient. And all these plaques can be quantified on the CT. The second thing we look at is spotty calcification. That is a small calcified plaque, which usually we have a Hounsfield threshold of 130, sitting in a lesion which also has mixed elements, which is lipid as well as fibrous elements. The third thing is positive remodeling, and you can clearly see that the vessel is actually expanded to accommodate the plaque, and this can be seen very nicely. And this is something which is missing on a luminogram. We can't really see that. And the last thing that we look, and which has the closest approximation to what you see on the OCT, that is a TCFP, is the napkin ring sign. And what you see here is the lumen, this is the lipid core, and more importantly, what is around is the fibrous cap. And not only the fibrous cap, but we look at the concentration here. So if it is bright, it means there's an inflamed fibrous cap, and these are the patients who are more inclined to get ACS. So looking at the whole constellation of signs that we see on CT, the positive remodeling, the napkin sign, spotty calcification, and the lipid attenuation plaque, helps us get very good OCT equivalence, although not of the same resolution. And if you look at the dual energy scanners that we have, we are now able to discriminate between a fibrous plaque and a lipid-rich plaque based on the Hounsfield units and the degree of the DIA, which is 0.016 in most machines, to differentiate both of them. We know that the features are important, so when you have these high-risk features, your MACE events go up compared to patients who don't have, and the more the number of vulnerability of a plaque you have, more the events that you have, and that is again clear. We also look at luminal stenosis on CT, and this is the grading of score that we have from 0 to 4A and 4B, and 5 is a patient who has a total occlusion. So CADRAD 0 has excellent prognosis, the arteries are clear, and the calcium is 0. CADRAD 1, you have fine plaques less than 30%, the calcium score is again low, 2.3. CADRAD 2 is up to 50%, you can see the vulnerable plaque, but there's no significant lesion. And CADRAD 3 has a borderline lesion of between 50 to 75% high calcium score, and these are the kind of patients who will need a functional imaging. CADRAD 4 without the left main is 4A, and here you find the plaques are more than 75%, and if it's 4B, there is a left main involvement. So in terms of accuracy, the sensitivity is great, but the specificity is poor, so it's very good to pick up disease. So when we put all these things together, you have a very good plan for the patient. So if you have a CADRAD 0, this patient actually, if the lipids are normal, doesn't need any therapy. CADRAD 1 is lipid therapy along with CADRAD 2, and CADRAD 3 needs functional imaging, and CADRAD 4, the patient needs to go to the cath lab, and CADRAD 5, the patient needs to have a viability assessment before he goes to the cath lab. So we have a very good ability to actually give a management plan to the cardiologist based on the CT. We are also looking at plaque, which means calcium, and we have a number, and we are also looking at the non-calcified plaque after giving contrast, and that's graded from P1 to P4, where P1 and 2 are mild to moderate plaque, and P3 is significant, and P4 means you have plaques in almost all the territories. So if you can combine the CADRAD with the P value, then you again have a very good management plan. So CADRAD 1 and 2 along with P1 to P3 is medical management, 3 is functional imaging along with medical management, and 4 would be an invasive angiogram with or without an OCT, and 5, as I said, would be viability along with an intervention. This is how the plaques look like on the CT, and we have different variety of plaques, calcified, partially calcified, with and without rupture. Now, the new thing that is coming into CT is what we call the fat attenuation index, and this is a very early marker of inflammation even without a lesion. And this is the cartoon showing you how the layer just outside, the peri-adventitia outside the vessel, is significantly inflamed with macrophages, and this is how it looks on the CT picture. And we now have software tools to actually look at the vessel wall around the lesions to look for early changes. And there is a tool to even quantify this FAI. And the higher the FAI, 70 is taken as the number, then the more the events that happen, and this has been shown in the CRISP study. Lastly, we now have workable software. This is from Siemens, where we can actually look at this particular issue. Now, the data from CT, and especially the Scott Hart study and the Japanese group, have clearly shown that if you evaluate a patient by CT and look at the low attenuation plaque burden, you are going to have a very good predictor of further events. There are similar other studies where they have found that the calcification itself in terms of mass, length, and volume are also very good predictors of future events, and that is captured very well on CT. And most important, we have a very good post-mortem study which says that if there is inflammation That is, if there is a significant take-up of the contrast of the plaque, both the adventitia and the intraplaque, then the events again are going to be very high. So, ladies and gentlemen, CT is a very good screening technique. It's completely non-invasive. The radiation levels are very low, almost less than 1 millisievert. It's a great screening tool and possibly the only non-invasive tool which can look at plaque currently. Thank you very much.